Welcome to the other side of Lucy Letby. In episode 52, we're going to continue with the Court of Appeal judgment that denied Lucy Letby the right to appeal. The highlight for me so far is the judge's interpretation of Professor Arthur's evidence. Of course, Professor Arthur said many things during the trial, but the judges highlighted his statistically irrelevant review of his own work in Great Ormond Street Hospital, which was a retrospective study of children in the wrong age group and resulted in 8 cases where gas was found in the great vessels. Not only was it statistically irrelevant, situationally irrelevant, it was also technologically irrelevant because Professor Arthurs relies on magnetic resonance imaging, MRIs, computerized tomography, or CT scan. He doesn't rely on portable X-rays and post-mortem X-rays. And I quoted a contrary piece of evidence that would have taken 5 minutes to put into evidence if Letby had her own expert that found the presence of gas in 89% of babies in this cohort who had cardiopulmonary resuscitation, meaning that it was likely that any baby who had cardiopulmonary resuscitation, and all the babies in the Letby series did have cardiopulmonary resuscitation, any of the surviving babies had a probability of 9 out of 10 for the presence of gas post-mortem in babies who had suffered collapse and had cardiopulmonary resuscitation. That, as I say, is just a fact. It was a published finding whose purpose was to identify the presence of gas post-mortem in babies who had cardiopulmonary resuscitation. And therefore, for the purpose of this trial, it had much more evidentiary value than the frankly meaningless report quoted by the judges in paragraph 48. And the fact that it isn't there, the overwhelming association with postmortem gas and cardiopulmonary resuscitation, is the fault of the defence. Because even if you don't put your expert in, you could have asked Professor Owens to comment on the many papers that make this association. In any event, we move on to paragraph 49, and this is count 1, BBA. Babies A and B were twins born by caesarean section at 2031 on the 7th of June 2015 at 31 weeks and 2 days. In medicine, we don't count the days. The delivery was straightforward. That's what the appeal court judges said. But the truth is that the delivery was anything but straightforward. These were twins that were born with one of them, baby B, in a precarious position, and the registrar, who was our own for a dangerous twin delivery, was forced to make a triage decision and spend more time resuscitating baby B rather than baby A. The judges continue on. At 2:58 on the 8th of June, baby A boy, was pronounced dead. At 0300, the following day, June the 9th, baby B, his sister, collapsed and required resuscitation but survived. Both babies were described by their treating clinicians and nursing staff in their evidence given at trial to have been in good condition in the period immediately before their collapse. Baby A required some breathing assistance but was otherwise stable. What the judges have said is totally untrue, as they pointed out here in the other podcasts. And the judges continue, baby B had been the first twin and had required more initial resuscitation than her brother, having been born blue and sloppy with a low heart rate. She was, however, at the time of her collapse, thought to be progressing well and to be stable. The truth is that baby B weighed only 1,600 grams. had a very difficult birth, was intubated, extubated, put on CPAP, desaturated when the CPAP prongs came out, responded quickly to face mask stimulation with oxygen, but then had a further desaturation, which apparently didn't respond and led to a second intubation to join the long list of babies in the Countess of Chester Hospital who went from intubation to extubation to CPAP to intubation to CPAP to intubation on a regular basis, something that would not have happened in a proper neonatal unit, where desaturations sometimes requiring resuscitative efforts are 10 a penny, but were dramatised in the Letby case for the purposes of the trial. And the judges carry on in paragraph 50. It was the prosecution case that the applicant who was standing by BBA's cot at the time of the collapse murdered BBA by deliberately administering error into his venous system through the line by which he was being given intravenous fluids, and that she attempted to murder BBB by again injecting error into her venous system. So the judges are just airbrushing the appalling management of the baby's glucose and electrolytes and ignoring the fact that BBA had been persistently tachypnea all day, and the only blood pH documentation for BBA showed persistent metabolic acidosis. In paragraph 51, the judges say that the shift leader on duty at the time of BBA's collapse said that she had never seen a baby look that way before. BBA was, she said, very white with sort of purply blotches and very cyanotic, which if you haven't seen before, you haven't seen any neonatal collapses because they all look exactly like that. Dr. Harkness, a registrar who was then in the 4th year of his neonatal training, an ST4, described the skin discoloration as purple, blue, with red and white patches, which were all over the body from shortly after the collapse until the time of his death. Dr. J. Ram, the ever-reliant Dr. J. Ram, the on-call consultant, arrived at 2023, which would place Dr. J. Ram at the event before Dr. Harkness said he was called to the event, even though he was in the room when it happened. Dr. Harkness said that he was called at 8:25 p.m. and the appeal court judges here said that Dr. Jairam was there 2 minutes before him, having been called from home at 8:27 p.m. according to Dr. Harkness. Dr. Harkness also said that at the time of BBA's collapse, the heart rate was 60 to 70 beats a minute, which means that any oxygen entrained from a 5 mil embolus into the venous system is long since gone and cannot continue to create a flitting rash. But who cares about any of that? According also to Dr. Jairam, as the judges continue, the skin was very pale to blue, but there were unusual pink patches, mainly on the torso, which would flit around. It was, he said, something that was very unusual and not something that he had seen before. It was so unusual, in fact, that he didn't bother writing it down. And the judges say he had, however, later become aware that his colleagues were describing a rash, which isn't actually a rash, it's a discoloration. And so the judges say he then undertook a literature review and came across the Liam Tanswell paper. He said he had remembered reading the description of the skin changes in that paper, which made him feel quite cold and worried. And in the last podcast, I told you that the Liam Tanswell updated paper from 2023 claims that this pink flitting rash was never reported by anyone in cases where the embolism has come about as a result of error entering the vein, either accidentally or from other causes. And the judges say that he categorically denied an allegation put to him by Mr. Myers that those descriptions, that's the Liam Tanswell descriptions, had influenced his account of what he had seen. He said he had undertaken the review precisely because of what he had seen, an explanation later corroborated by contemporaneous emails. Well, a lot of things have been corroborated by contemporaneous emails released during the farewell inquiry. And another appeal court judge in the case of BBK called out Dr. Jeran for being an inconsistent witness. And I would say someone who is economical with the truth and who hasn't seen the end of the Lucy Letby debacle. And then in paragraph 52, we get Dr. Evans said that he had prepared a number of reports about BBA, but that he had not known about the reported skin discolorations when he had first made the diagnosis of our embolism, as the witness statements of the medical professionals treating BBA had not been sent to him. He made the diagnosis on the basis that 1. BBA had collapsed suddenly when in a stable condition. Not true. There was no evidence of infection or lack of oxygen. Not true. All of the lactates measured on the baby once he had left the delivery suite and measured last 6 hours before he died were elevated, meaning that there was evidence of lack of oxygen. And Evans carries on that the modest fluid loss, which had resulted from a delay in putting the line up, had not been sufficient to cause the sudden onset, unexpected collapse. Untrue. The baby, who was only 1,600 grams, went 4 hours minimum without glucose and would have by then exhausted his very limited stores, something that Dr. Harkness could have put right when he first discovered that the baby had no dextrose running at 5 p.m, but chose to ignore for another 3 hours. And carrying on, Evans says, 3, the sudden collapse of babies, even in the neonatal unit, was unusual. Not true. Typically, there would be warning signs, and babies do not go from a normal heart rate and normal oxygen saturations without some warning signs. But we had the warning signs. We chose to ignore them. Section 4, he says, when he had prepared his first report, the only other contender for the collapse was the administration of a noxious substance. But he accepted in his evidence that there was nothing to support that diagnosis. He was therefore left with air embolism as an explanation. And in section 5, if the witness's accounts were reliable, then the pattern of discoloration and flitting movements was what you get in air embolisms. Again, untrue. There are non-specific signs of shock and collapse that have multiple causes and no cause in many cases. And then we move on to a real classic that can only come from people who know nothing about medicine. Paragraph 53, his conclusion, that's Evans, that air embolus was the cause of the collapse was therefore based upon a combination of factors. Individually, none of those factors were diagnostic of air embolism. I think we need to read that again. Individually, none of those factors were diagnostic of air embolism. How can a patient who has no symptoms of an illness have an illness? So none of the observations or findings of the baby pointed to a diagnosis of air embolism on their own, but when you combined them, the only thing you could get was air embolism. But even if that was the case, there remains the need for a diagnostic criteria for air embolism. So to make a definitive diagnosis, you have to have the clinical presentation. Some deterioration, cardiac abnormalities, skin discoloration perhaps, respiratory distress perhaps, Neurological changes, seizures, uncoordinated movements, irritability, and then the measurements. Decrease in end-tidal carbon dioxide concentration, the visualization of error in infusion lines or in retinal vessels, chest x-rays showing error in the cardiac chamber or vessels at the time of the incident, or a cranial ultrasound at the time of the incident, transthoracic or transesophageal echocardiography, Doppler ultrasound, CT scan, and then we have to have the circumstances, or what we call the predisposing factors. The two most common by far, accounting for upwards of 90% of our emboli, are the predisposing mechanical ventilation and central venous catheters, meaning that even if you are right with your diagnosis, it is impossible to say where the error came from unless it's glaringly obvious. And this is the bit that these judges don't seem to get. Even if they agree with Dr. Evans, the least likely reason is not the reason that you plump for first. In a circumstance where a baby is on a ventilator and they have central venous lines in the case of baby A, two central lines in, one of which is attached to nothing and has been in place with no fluids running through it for at least 6 hours. Those have to be the likely causes of any air embolism, and to say otherwise is fraudulent. Let's look at another more common than you think condition and see if we can construct it from individual traits. Lack of empathy, shallow affect, lack of remorse or guilt, superficial charm, grandiose sense of self-worth, pathological lying, manipulative behavior, impulsivity, poor behavioral controls, the need for stimulation and excitement, parasitic lifestyle, lack of realistic long-term goals, and irresponsibility. I would say that pretty much fits nearly every teenager I've ever met, but it also pretty much fits every psychopath I've ever met. Does that mean that every teenager is a psychopath, or every psychopath is a teenager? I think perhaps we should ask Barry Evans. He'll know. And then in paragraph 54, we have Dr. Bohan coming to the fore. Dr. Bohan explained that she would have expected BBA to have had a number of problems in the neonatal period, but surprisingly, he had not had. And whilst he needed some respiratory support, he was breathing room air. She accepted that it was not ideal that the baby had been without fluid for 4 hours, when the evidence from the trial actually shows we don't know if it was more than 4 hours or not, because the nurse present during the day shift stated so in her evidence. And again, we're not talking about fluids alone here. We're talking about glucose. It's doubtful whether any baby who weighs 1,600 grams and is breathing at 60 to 80 times per minute in room air for a large part of the day has sufficient glucose stores to sustain that. And running out of glucose would cause a rapid and fatal collapse, no matter what Dr. Bohan wants to say. And it continues, she disagreed with the suggestion that a baby in this condition might deteriorate dramatically and suddenly. She accepted that babies who collapse may have rashes and they may go grey, blue, or white, but they don't have the type of rash that was described in A, with his pink blotchy rash that seemed to fluctuate and come and go. So the judges don't seem to realise that they're actually quoting two different opinions from the so-called prosecution witnesses. We have Dowie here saying that no single rash or skin discoloration tells you that there's an air embolism, and Sandy saying that there is. But the accepted truth is that there isn't, and the pink flitting rash that we've already had an explanation for that cannot happen because of the ideal gas laws and how physiology works is a red herring. In fact, it's a flitting pink red herring. And in paragraph 55, Professor Arthurs said that BBA's imaging showed the gas that would normally be seen in a post-mortem state. There is no such thing as the gas that would normally be seen in the post-mortem state. But they carry on. There was, however, another line of gas just in front of the spine. This was an unusual finding in the absence of a bony fracture or overwhelming sepsis. The presence of the line of gas was unexplained. But, oddly enough, he noted that baby A had an umbilical venous catheter in situ, and gas can be introduced into vessels through catheters and devices. He also had a long line. He, that's Professor Arthurs, concluded that the most pragmatic conclusion was that gas had been introduced via one or other of those lines. But, he said, the imaging is not diagnostic of how the gas was introduced. All the image shows you is gas in one of the large vessels of the body on a post-mortem radiograph. It was therefore consistent with, but not diagnostic of, air having been administered to BBA. In other words, we have zero proof that there was air in BBA ante mortem before death. So the instruction to the jury should have been that you must ignore all of the x-rays, and if you conclude that there was an air embolism in baby A, you must also accept that you cannot determine the origin of that air. In other words, you have to find Lucy Letby not guilty of putting it there. But I don't think that the defence said that to the jury. And the laughs just keep on coming. In paragraph 56, Dr. Marna Reedy's identified the presence of a nerve bubble at post-mortem histology of the brain and lungs. No, he did not. He did not identify error anywhere because histology is not capable of doing that. He said that the presence of the air bubbles was highly suggestive of air embolus, although not conclusive. Therefore, the jury should have been told that they had to disregard his suggestion of air embolus because it's not conclusive. And if it's not conclusive, it's not sufficient to even begin to prove Dowie Evans' ridiculous theory. It's outrageous, in fact. So the judges aren't doing too well so far as I'm concerned. They have a really easy job. You don't need a law degree for this or any experience. All you do is repeat over and over again what was said at the trial. You don't have to concern yourself at all as to whether anything that was said in a trial was remotely true or even possible. Because it was said at the trial, it has become miraculously a fact. In paragraph 57, we carry on with the same. This is count 2, baby B. Baby B was baby A's female twin. The applicant was on the night shift of the 9th to the 10th of June. Her two designated babies were in nursery room 3, and baby B was in nursery 1. Nonetheless, the applicant became involved in baby B's care and took blood gas readings for her at midnight. At midnight, Nurse W was in the nursery drawing up medications when the monitor alarmed. She said that baby B looked very pale and ill and had blotchy skin. She recorded that baby B was cyanosed in appearance and that her colour changed rapidly to purple blotchiness with white patches. In her 20 years' experience as a nurse, she had not seen such skin discoloration before. Dr. Rachel Lambie was present. She was the registrar. Her unchallenged evidence was that the most memorable thing about Baby B was her colour. She was dusky, and then there were patches of discoloration on the skin that were sort of reddy purple. It would flash up, it lasted about 10 seconds, disappear, and then reappear, and it was flitting around the body. She said that the skin discoloration was very unusual and not something which she had seen before or since. It was a very strange and profound colour change. Dr. Y, a consultant pediatrician at the hospital since 2005, saw discoloration which was purple and affected the right abdomen. She too was puzzled by its cause. And so we've reached paragraph 58 of this Court of Appeal ruling. And what have we learned? We've learned that no one witnessed Letby do anything, that no one made observations or findings which on their own pointed to a diagnosis of air embolism. And we've learned that the confirmation of the diagnosis air embolism were X-rays that don't on their own confirm air emboli, and some histological findings that don't on their own confirm air emboli. We have a big fat ball of nothing that you won't find in any pathology book, any neonatology book, under the label air embolism. We already know from the 2023-2024 update of the Liam Tanswell paper by its original author, Professor Shu Li, that skin discoloration is a non-specific finding, and that air emboli that gain access to the body by entrainment of air into the vascular system directly are not associated with skin discoloration at all, and that all of these skin discolorations are the non-specific consequence of the pathophysiological consequences of shock from any cause. And shock is the failure of the circulation for any cause. 58 paragraphs so far that confirm everything that I've said to date, that this does not constitute evidence of air emboli, and even if it did, it cannot provide any remotely reliable explanation for why the air embolism occurred. But likely, as with 90% of all reported known air emboli, that the cause was mechanical ventilation or entrainment of air into central venous catheters. In paragraph 59, Dr. Bowen confirms, of course she does, that Baby B was stable before her collapse. But which collapse was that? Baby B had at least 3 collapses, so-called. Remember, these are desaturations, apnea attacks, episodes of bradycardia. These are the bread and butter of neonatal care. One paper I quoted in a previous podcast gave a figure for around 60 such events in preterm babies every day, some of which require intervention, some of which do not. If a baby goes without oxygen for more than 30 seconds, the baby will get mottling. Believe it or not, mottling is so common that there is actually a thing called the mottling score. And this mottling score is used to predict survival after septic shock. So not only should these doctors have been able to properly describe the rashes or skin discolorations which they all supposedly observed, they should have been able to score them. But it turns out that pediatricians are crap when it comes to skin rashes or discolorations or manifestations. A study of 1,551 pediatric dermatology visits found that 48.2% of skin diseases were misdiagnosed, including the really common ones such as molluscum and tinea, which had a misdiagnosis rate between 62% and 71%. When it comes to skins, pediatricians are pretty crap. But in paragraph 59, Dr. Bowen accepted that her diagnosis was based upon excluding other conditions, but she said she had been struck by the description of florid skin changes observed by nurses and clinicians who had each remarked that the changes were very different from anything they had ever seen before. She said that she knew from her research that skin discoloration can be present in cases of hair embolism, whereas in the majority of cases of hair embolism, it's not present at all. And when it is present, it's not present when it enters the vein directly, according to the most recent review. And then she goes on to say that she made her diagnosis, therefore, by excluding other conditions, and because of the discoloration, she accepted in cross-examination that the fact of discoloration in itself does not make the diagnosis one of hair embolism, nor does it even come close. In fact, in the Lane Tanswell paper, which she quoted, roughly 1 in 10 babies had some kind of skin discoloration, which was, as I say, non-specific generalized mottling. And then we get to count 4, baby D, paragraph 60. Baby D was born on the 20th of June 2015 at 37 weeks gestation. She weighed 7 pounds. She died aged 36 hours at 4:25 on the 22nd of June 2015. And then we get to paragraph 61. The first of 3 events occurred at 1:30 on the 22nd of June 2015 when the designated nurse was on her break. Now, this is just a flat-out lie. The first event occurred 12 minutes after birth, when baby D had a major collapse, and which Dr. Bowen blamed the father on. Nurse Percival called her back, checked on baby D and found her to be settled and stable. She checked again 10 minutes later and found her to be satisfactory. Shortly after this, monitoring alarms went off and baby D was found desaturating and her heart rate dropping. This time, Nurse Percival called her back, said that baby D had a reddy blue, reddy brown rash. And unsurprisingly, she said she had not seen anything like it before and described it as being like a mosaic. Baby D's designated nurse described baby D's skin discoloration as being dark and unusual and deep red-brown colour. 2 different descriptions in the same baby by 2 different people. And this nurse had not seen anything like this before. Dr. Bruntman, the on-call register, arrived at 1:40 and recorded the presence of extreme mottling with tracking lesions which were dark brown black across the trunk. 3 descriptions of the same rash or discoloration in the same baby. And this is a perfect description of livido reticularis. So livido in Latin means bluish and reticulum means lace-like. So a bluish red lace-like pattern, which is what is being described here. It's quite common to hear amateurs refer to reticularis or reticular-like rashes as mosaic-like, and livido reticularis is caused by a temporary interruption of blood flow to the skin for any reason and is not specific to any single disease and is very common in preterm babies, even in term babies. But the less oxygen present in the circulation for any reason, including apneas of prematurity, which are the main reason that babies don't breathe because the brain is underdeveloped. The more profound the desaturation, the more deep will be the blue coloration perception. In other words, it'll look purple. So this is all hokum pokum. It doesn't mean anything. And we have to recall, of course, that baby D had sepsis by this stage. And so damaged were the lungs of baby D because of his incompetent care that he developed what's called acute lung injury. And acute lung injury is a hyperinflammation, which is a destructive process in the lungs, which in the presence of pneumonia will almost certainly lead to death, and which was confirmed by the postmortem. In paragraph 63, we have Professor Arthurs coming back, and he identified a striking black line from left to right in front of the spine, which was either gas in the aorta or the inferior vena cava. He said that he had never seen this quantity of gas in one of the great vessels where no reason, for example, sepsis or trauma, could be found. But what he didn't say is that you cannot quantify gas on a two-dimensional X-ray, and he doesn't appear to know that the baby had sepsis. But he went on to say that one of the explanations for this, the least likely by far, of course, was that someone had injected air into the baby. In the absence of any evidence that baby D had died from something like overwhelming sepsis, for which there was plenty of evidence, he concluded that the radiographs were consistent with air embolism, which I think is a quite astonishing thing for a person of his experience to say. And I think it's extraordinarily more so because he already said in evidence that only an X-ray taken at the time of the air embolism and showing the presence of air in the chambers of the heart was the means by which you could diagnose air embolism. Post-mortem X-rays are absolutely useless, and I doubt any other jurisdiction in the world would allow them into evidence at all. In paragraph 64, Dr. Marnariti said that the presence of gas in the large intra-abdominal vessel was significant and that body decomposition could not explain its presence, nor, in his view, could the presence of infection explain the death. And again, this evidence is truly astonishing. Intravascular gas accumulation is one of the earliest signs of putrefaction visible in postmortem imaging of any kind. And gas can be seen in both the arterial and the venous vasculature, and it's usually symmetrical, but not always. In a study of 73 non-putrefied cases, gas accumulation were present in 98% of trauma cases and 80% of non-trauma cases, with vessels being one of the most commonly affected areas. And it accumulates rapidly after death. Even in premature babies, gas can be seen accumulating in cardiac chambers and major vessels within hours of death. And the origin of this gas is primarily putrefaction, the process of putrefaction, as enteric bacteria, that's bacteria in the gut, continue to produce gas after death. The bacteria aren't dead, the patient is dead. And the false positive finding of vascular gas can occur due to a phenomenon called off-gassing, which begins about 4 hours after death and can occupy the arterial topography. And pneumonia, which was clearly present before death in baby D, and which was obviously fulminant, is the cause of death for about 10% of all baby deaths in the world. But yet, Dr. Marnariti says that the pneumonia and consequent sepsis couldn't have been the cause of death for baby D. How can he say that with a straight face? In paragraph 65, Dr. Evans said that baby D was stable and that the sudden nature of her collapse was incredibly unusual. She was recovering from pneumonia at the time of her collapse. The skin discoloration, here we go again, which came and went, was not something which had been seen in a neonate before. The events were all therefore consistent with air embolism. Bullshit. Paragraph 66, Dr. Bowen said that baby D had been born in good condition. Yes, born in good condition with pneumonia. But despite being born in good condition, as Dr. Bowen says, she goes on to say that baby D's pneumonia had stabilized and was recovering at the time of her collapse. Very graphic description was given of the nurses and the doctors present of the skin discoloration associated with the first two collapses, and this sort of discoloration fitted with previous cases of air embolism in adults and to a lesser extent in children. Bullshit. In concluding that the cause of the collapse was air embolism, She had exclusive conditions which featured on her list of differential diagnoses and was therefore, she said, left with looking for something which was unusual and odd. And that's exactly how we do medicine. We find a patient collapsed, we do x-rays, we find pneumonia, we do another x-ray, we see the pneumonia get worse, the baby dies, we do a post-mortem, and we find that the cause of death is pneumonia. And the only odd and unusual thing was that it was allowed to happen in the first place. In paragraph 67, Dr. Bohan goes on to shoot herself in the foot again. She accepted in cross-examination that discoloration of the skin could be caused by conditions other than air embolism, and that it was not possible to say what pattern of skin discoloration is specifically distinctive to an air embolism. What you just said is that in terms of making a diagnosis, skin discoloration is useless when it comes to air embolism. But then she goes on to contradict herself, and she says, however, she said that the patchy discoloration that came and went was compatible with an air embolism, taking into account the clinical situation which we had. How can judges read this stuff with a straight face? A non-specific sign, which she admits is non-specific, has now become specific for the purpose of this trial. And the clinical situation that we're talking about here is the wipeout of one lung in a newborn. And 67 continues, it was put to her by Mr. Myers that if discoloration of the skin were to be used as a means of identifying air embolism, then we need to have something which marks that out as an air embolism rather than anything else. Which, of course, we can't do because Dr. Bohan has already admitted that it is not a specific sign. But Dr. Bohan goes on to say, I'm not using discoloration alone. It is the constellation of features, not just the clinical discoloration, although that absolutely forms part of it, because what we have seen described by clinicians quite consistently does not fit with any other known pathological process that I have seen in a neonate. She continued, those types of skin lesions have been previously described in air embolism. We're looking for those patchy, not mottling. I won't use that term because that will confuse people into thinking that mottling that we see in babies when they are in extremis for other reasons, these were described as tracking lesions. In some cases, they were described as circular oval lesions with a reddy brown discoloration that came and went. So where in the case did anyone describe any of the rashes as tracking? And if the skin discoloration was tracking, what was it tracking? Then in paragraph 68, we get baby M. And again, we have a baby collapsing, 33 weeks, born in good condition, nothing to worry about. Paragraph 69, more of the same. And then we get to paragraph 70, where we get the most reliable witness in the entire charade, the man who wears a watch in a naked below elbow ICU. And the judges say of Dr. Jairam that Dr. Jairam attended and noted that baby M was generally pale, which he would expect in a cardiorespiratory arrest, which is what we're witnessing. Heart and lungs not working. So nothing unusual so far from Dr. Jairam. But what's this? There were patches of very bright pink, or certainly more obvious pink, that flitted about in the sense that they would appear and disappear, and then other ones would appear and disappear. Dr. Jairam said that once the circulation was restored and baby M's heart rate got above 100, the pink blotches vanished. He said they were very similar to the ones he had seen on baby A. Seriously, would anyone listening to this buy a second-hand car from this man? And then in paragraph 71, we have Dr. Jairam continuing on with this blustering. Dr. Jairam was once again challenged by Mr. Myers about the absence of any note of the unusual skin discoloring. And he explained, and we all believe him, that his priority at the time was with dealing with resuscitation, explaining things to the parents, and then working out post-resuscitation care. He also said he was not aware of the clinical significance of the discoloration at the time. However, he said that in June 2016, after a number of further unusual, unexpected, and inexplicable events on the neonatal unit, the whole consultant body at the unit had sat down and addressed the need to work out what was happening. One of the possible explanations which had emerged from that conversation had been air embolism as an explanation for the collapses. The meeting prompted him to do a literature search, which is when he found the Lee and Tanswell paper. He said that the following morning he had sent the link to his colleagues because that paper seemed to have described the skin discoloration that he and others had seen. When questioned further by Mr. Myers, he said that it had certainly not been the case of let's look for something and we found this. Let's make everything fit with this, because actually that wouldn't be the right thing to do, and there would have been no reason for me to look unless we'd seen this. So Jerram's telling us that the most important piece of evidence was this skin discoloration that appears in every one of these paragraphs, but which he didn't record at the time, but added later to his story. That can only stand up when we attribute some magical power to this skin discoloration, which doesn't in fact exist. Now, let's just return to paragraph 67, when Dr. Bowen says that it was not possible to say what pattern of skin discoloration is specifically distinctive of an air embolus. That being the case, we can have an air embolism without skin discoloration. All the other circumstances surrounding the situation where an air embolism comes about are present. But in our thought experiment, we're going to leave out the discoloration, because discoloration of the skin was not present in 90% of the air embolisms included in the Lee and Tanswell paper, and is not included in any of the air embolisms described in the 2023-2024 update on the Lee and Tanswell paper, particularly when the air embolism comes about by air entering the vein directly and not entering by way of a ventilator. So we take away the rash. What are we left with? Well, not very much. See, the con here is that each of these components of this clinical picture that equals air embolism are not important on their own, but become important when they're combined. It's a con job, a 3-card trick. It doesn't matter what disease you're talking about. The observations and the findings come about from the disease process. So let's take, for example, a disease that generally involves the presence of a rash, and that would be shingles, otherwise known as varicella zoster. So the presentation of varicella zoster or shingles is usually a painful area of skin with a distinctive rash. And the distinctive rash is basically just chickenpox, and the area that the chickenpox affects in shingles is restricted to the distribution of a nerve. But do you need the rash to make the diagnosis? No, you don't. Very often people will present with pain, and the distinctive nature and distribution of the pain tells you that it's likely to be shingles. Sometimes when a person gets shingles, the pain can go on for months. And sometimes when you give the person an antiviral medication, it stops that from happening, so that the shingles is only a short-lived, painful experience. The question remains then, do you wait until the rash shows, or do you use the treatment before the rash shows? The treatment is very expensive, and you have made your diagnosis without the rash. Generally, I would have went ahead and used the antiviral drug. So I would have been quite comfortable taking the rash away from the diagnosis of shingles because I had lots of other things that supported the diagnosis: nerve pain, neuralgia, and very often slight loss of sensation in a distinctive dermatome area. But in this situation, we have Dr. Bohan telling us that we don't need the rash to diagnose the air embolism in the cases involving Lucy Letby. But if we take it away, what are we left with? Every single one of these paragraphs that I just read out, from paragraph 49 right down to paragraph 80, requires the presence of the rash. Otherwise, there is little or no substance to the paragraph at all. So the trick is to tell the truth and say that the rash does not diagnose our embolism, but at the same time to lie and say that it lends credence to the diagnosis of our embolism when it does not. Like the diagnosis of shingles, it should be possible to make that with or without the rash, whereas that's not the case for Gary Evans' air embolism. And then we have to consider what the judge has already said as well, that the rash or the skin discoloration created by this air embolism was as a result of the direct oxygenation of red blood cells adjacent to free air. But sadly, even if that were true, which it is not, there isn't enough Letby air to create this flitting, coming and going rash. And remember, Evans told us that he reached this diagnosis without knowing about skin discoloration. But strangely enough, since finding out about skin discoloration, we don't ever hear Evans talking about air embolism without talking about skin discoloration. So another one of his tricks was to squeeze his diagnosis in without the air embolism, while at the same time mentioning the air embolism, so that in effect, Evans' diagnosis of air embolism was never defined in the court without the presence of non-specific skin discoloration. It's a very sneaky, very clever little move. And what do we have to back up our diagnoses? We have useless x-rays and useless pieces of histology. And the cherry on the cake is to ignore all the other findings at the original postmortems, or in some ways to corrupt those findings. And we will look at some point at how the findings of the original autopsies were corrupted. Remember, Dr. Marinarides originally found exactly the same in the case of baby A. He reached the same conclusion as the original pathologist in his review of the autopsy of baby A, and then corrupted it later with the finding of air embolism, which he did not make independently on his own. As a scientific exercise, this whole thing stinks, and so far in this so-called appeal hearing, we could just as easily have used AI to create a summation of the trial. So far, we have almost 80 paragraphs, page 20 of 58, and the judges haven't brought anything to the table. All they've done is parrot over and over again the same nonsense that the jury were told during the trial. How is this possible? And for me, it's only possible because of the defense. It is very easy, believe me, for any doctor who's ever worked in neonatology to go there and give a very convincing story as to why these babies actually collapsed. And it should have been easy to get more than one person to do that. So even though it's tedious for me going through this again, I'm sure it's tedious for you, the listener, going through it again, if you're doing so, I want to cover the trial, the Court of Appeal judgment, and in due course, all of the releases from the Thirlwell inquiry. Because to date, I have heard nothing new, and sadly, I've heard a lot that corroborate what I say, caused these babies' deaths and refute absolutely the evidence given by these other experts. So we'll leave this episode now, and in the next episode, we'll move our way through this Court of Appeal judgment until we get to the end. So I'll see you in the next episode. Bye.